600 people this morning also streamed in across Canada. I'm glad that you can stop swearing at your computer screens. Apparently it's live now. So welcome to those who are here and who had to wait a little bit longer, and especially welcome those who are also logged in from all over the place. So yes, my name is Ron Postuma. I'm at McGill University. And I'm going to talk to the second part of this talk, which is what we call the everything else of Parkinson's disease. Okay, and this is a brain of a person who's obviously died, who had Parkinson's disease. I don't know if anyone can guess which is the Parkinson's. See that black stuff? So black is bad, I guess. No, it's not. It's good, okay? The people who have the black stuff, that's neuromelanin, the same pigment that we have in our skin, which Dr. Anang mentioned already, which is normal, and the brain on the left had Parkinson's disease. And so this was what Parkinson's disease was in 1970, 1980. However, it's become clear since then that the Parkinson's disease has changed considerably, and there are a whole host of other parts of Parkinson's disease, which I'm going to cover here, which we're calling the everything else. And so Parkinson's also involves troubles with olfaction, difficulty with mood, visual changes, the autonomic system, cognitive problems, sleep disorders. All of these things are not rare. Not one of these things is rare at all in Parkinson's disease, and the majority of people with Parkinson's will have numerous of these. So how come in 1970 or 1980 I would give a talk and I wouldn't mention any of this? Well, in fact, this is an artifact not of ignorance of the previous age, but an artifact of the amazing successes that have happened in Parkinson's disease. So if you had Parkinson's in 1960, you would present with your tremor or your slowness or your stiffness, and you would be in a nursing home maybe 4 or 5 years after your disease onset with terrible disabling motor aspects of Parkinson's disease. Then levodopa was invented, one of the really great miracles of modern medicine. And all of a sudden, people who were unable to walk awakened and were able to get up and were able to move. And then we had trouble keeping the doses of levodopa stable. And so then in the 1980s, we'd be talking a lot about motor fluctuations and dyskinesias, and these are still a problem, but we're getting much better at treating the dopamine system, and in fact with surgery and other things like the duodopas, we actually can take care of the dopamine system pretty well. And so now that people are living longer, and now that they're no longer just having a host of terrible disability issues related to Parkinson's because they're untreated, we can see that these things are there. We can see them now because the rest is okay. And so this is in fact an artifact of our success that we recognize this. Dr. Anang, I think, showed you this slide, okay? This is the Lewy body that you see in Parkinson's disease, just looking at the arrow there. And so in 1998, there was a family, they were Italian origin living in Greece, called the Contorsi kindred. And there was a massive family, and about half of them got Parkinson's disease. And it was determined that their Parkinson's disease was caused by a gene, and the gene was called alpha-synuclein. And so people said, well, let's go look and see if there's alpha-synuclein in the brain. And in fact, there was lots of alpha-synuclein in the brain. And these Lewy bodies that used to be hard to see, that little pale pink thing, not that really bright pink thing actually, but the really pale one that's a little bit down and to the left. I don't have a pointer, so I can't show you. Now, all of a sudden, glows red. And so you can see these Lewy bodies much easier than you used to be able to see them. And when you started to be able to see them, you could start to be able to find them in places where you were not looking. And this was a paper, I guess it's about 15 years ago now, which has really changed the field of Parkinson's disease. This is the staging system of Heiko Brack. He's a German/Dutch neuropathologist who looked at autopsies just of people in the general population and went hunting for this synuclein protein. And what he found is that Parkinson's disease, in fact, is a disease diffuse around the nervous system. And so at the earliest stages of Parkinson's disease, you see the difficulty, you see actually synuclein not in the motor areas, but in non-motor areas, so olfactory areas, the dorsal motor nucleus of the vagus, which is involved in the constipation, autonomic functions, the sleep regulating areas, and it's only at sort of mid-stage Parkinson's disease that the actual the substantia nigra, which is the area that I showed you earlier, starts to become affected. And you're really not presenting with Parkinson's until you're stage 4, stage 5, something like this. And so the point is, Parkinson's disease is not just a motor disease. And if you think you're going to fix Parkinson's disease by, say, putting stem cells in the substantia nigra, you're not going to do any progress because you're only fixing one of the problems. This is a disease that affects many, many areas of the nervous system. And this is why the people with Parkinson's disease have all of these problems. Okay, so what are they and what can we do about them? Really, we're going over pragmatics mostly. I'm going to give you some new science, but mostly we're talking about sort of practical day-to-day issues in this talk, okay? But I want to start with a cautionary note because I'm going to run through a very, very long list of non-motor manifestations, and it's going to get pretty hard to listen to them all, okay? Some of you are going, oh yes, that's me, oh yes, that's me, and other people are going, oh my goodness, I hope that's not me, okay? Not everyone gets everything in this list, okay? And so I don't want you to think that Parkinson's is all the same. I'm actually going to show you, I'm going to start you off with a bit of tough science, and don't worry, I'll ease up on you later. Let me illustrate this with a recent study that we actually published in the same actually journal that Dr. Anang showed, which is Brain. Dr. Anang was involved in this as well. And so what I want to show you is how different Parkinson's can be from person to person. So you've heard of artificial intelligence and machine learning. We applied one of the earlier machine learning protocols called a cluster analysis to a very large cohort of Parkinson's patients who are all really at the start of their Parkinson's. And what you do is you take everything you can figure out about a patient. So how old are you? Are you a man or a woman? How long have you had disease? What medications are you on? Do you have constipation? Do you have this? Do you have that? Okay, you put everything about that one patient, okay? And you put that into a computer program and you say, computer program, sort the patients. Okay, cluster the patients. And it's not as easy as it sounds. Actually, it takes a lot of human work to sort of make sure the computer is doing what it's supposed to be doing. But then it divides people into groups. And then what we did is we started to analyze the groups that it would divide. So who are the people in this group? Who are the people in that group? And tried to describe the different groups. And then took it one step further and made rules. So you could assign patients to one of those groups. And the statistical programs can't do it. Only a human being can really do that. And then we started looking at the subtypes of disease. And this is one of the subtyping solutions that's out there. But what we found is that Parkinson's disease divides very quickly into a very large majority of people and a smaller minority of people, okay? So the large majority of people are in the pure motor and intermediate aspects of Parkinson's disease. So there is about a subset of about 1/3 of people with Parkinson's who really just have motor Parkinson's, a bit of constipation, a bit of olfactory loss, but nothing really else wrong with them. At the other extreme is what we call the diffuse Parkinson's disease, where people are presenting very early with lots of these non-motor issues like concentration difficulties or all the things I'm going to show you. And in between is a group of about half of them where they're sort of mixing the two up. And there's massive differences in the prognosis between people depending. Okay, and the people in the diffuse group, as I'm sure you would imagine, have much more troubles in life and they progress much more quickly. What's really interesting about this also is that what really determines what group you're going into is not your motor state really at all, but it's mostly the non-motor aspects of your disease. So whether you act out your dreams at night, whether your blood pressure drops when you stand up, what your cognition is like, and to a lesser extent your motor, are really the 4 things that determine what group you're going to be into. So that was a bit of science, okay, but I just wanted to show you this. This is a fast-moving field. We're starting to be able to separate patients a little bit, and it's really taking off now in recent years. And the other reason I wanted to show that to you is to say not everything you're getting in this list applies to you personally. Good. So let's start running through some of that list that I showed you earlier. Okay. Let's start off with kind of a neat one. It's olfactions, your ability to sense smell. Okay. So it turns out that almost 90%, 80 to 90% of Parkinson's patients have lost, partially or completely, their ability to smell. And many of you are unaware of this. Okay. It's quite specific. It only happens in Parkinson's disease and related disorders, and in the other mimics of Parkinson's disease, MSA, PSP, or this other list of things that look like Parkinson's, the smell is usually quite normal. And so in the new diagnostic criteria, it actually goes in there as something that can help you make the diagnosis of Parkinson's disease. And you test it with what you see on the bottom right there. That's, I don't know if you used to play with them when you were kids, those scratch and sniff things. You would scratch something and then you sniff it. That's exactly what this test is. You scratch a little thing and you try to identify the odor. And it looks like about 90% of Parkinson's have an impaired ability in this. Unfortunately, there's not anything you can really do about it. It's just kind of good to know, okay? So you are not the natural gas leak tester of the house, okay? Somebody else is, all right. So vision, there are some changes in the eyes of people with Parkinson's disease. It's partially related to the eyes themselves, and actually probably mostly related to the processing areas that are responsible for sort of telling you what you're seeing. And they're relatively mild, they're generally not a big deal, and there are two problems. So if you look at the bottom on the left, the Parkinson's patients might have a relatively difficult time telling the difference between the gray bars and the black bars. Okay, so that's called contrast sensitivity. And why is that important? Because that can have a lot of implications for driving. So many people who find it's very, very difficult to drive at night, you may be finding it partially because your contrast sensitivity is not so good. And so the subtle grays that come out in the middle of the night are more difficult for you to tell apart. The other one is color vision. There's a few men in this room, only men, who will not be able to see the 56, okay? You have congenital color blindness if you don't see that 56. But everybody else, including the Parkinson patients, it's not that problem. It's the difficulty in sorting the yellows and the blues. It's a relative loss. It's just kind of an interesting thing to know about. That's not really important, but the contrast sensitivity, that's maybe some of the reason why you don't like to drive at night. How about depression and anxiety? About a third of patients with Parkinson's disease can develop some sort of depression or anxiety, but it's not the same depression. So when you think about depression, what you think about is sitting in a room, crying, tears, my life is worthless, I'm a terrible person. That's the sort of standard issue depression that people, in the general community get. In Parkinson's disease, the depression is somewhat different than that. None of the guilt, none of the shame, not a lot of tears, actually. That's one thing that we notice. It tends to be more of a flat, nothing's fun anymore, and anxious. Those are the things that people are dealing with. So I have lots of Parkinson patients who, they're coming into the clinic and they're usually their wife or husband is saying, she's been worried about this stupid appointment for the last week. She can barely sleep because she's coming to see you. And I'm like, come on, we met each other 10 times. There's nothing to worry about. But it's just this rumination about things in advance. It can be very frustrating to deal with if you're that person. And then the apathy, not really wanting to do anything. That tends not to bother the person themselves that much. That drives the family crazy because the person doesn't want to go out anymore. And so if that's experiencing you and your husband or your wife is being driven bonkers because they want to get out, you just have to get out, okay? Because you're apathetic and they're not, and you have to help them lead a full life. Some people notice also a little bit of flatness, that things just aren't as fun anymore. Now, not everyone gets this, but if you're experiencing that, that's actually part of the disease itself. So some people would say, I have Parkinson's, I can't move as well, so I'm feeling, anxious and sad. That's not really it. It's actually part of the disease itself. And some of the neuron systems that are responsible for regulating our levels of anxiety, for regulating our mood, are degenerating, just like I showed you on that map earlier. And so it's part of the disease itself, and it's a little bit biochemical. And so you don't necessarily need to hesitate if you're thinking about, do I need an antidepressant or anti-anxiety agent? You can think of it like a levodopa in a sense, replacing a chemical that might be missing. The treatment in Parkinson's disease, other than sort of keeping active, and which is of course very important for all of Parkinson's disease, the medications, there's some intriguing things that some of the old-fashioned medications for Parkinson's might work a little bit better. The old-fashioned medications for depression might work a bit better in Parkinson's disease, perhaps because they help you sleep, etc. But you can run into side effects with that. So it's really something you need to discuss with your doctor about what the best option is. Hallucinations. So hallucinations do occur, okay? They're commonly associated with the medications. However, they can happen even in people who have not ever had medications in their life. So it's a combination of the disease and the medications themselves. And they're very classically visual. So there's actually quite a stereotypical evolution of this hallucination. People will notice that a spot on the wall looks like a bug, and then the spots on the wall that look like bugs start to move a little bit, and those are little illusions that can happen early. They can be normal as well. So you're walking at night and there's a chair, and for a second it looks like a person, and then instantly you go, no, that's not a person. Okay, in Parkinson's disease, that system that tells you, no, that's not a person, doesn't work as well. And so that chair continues to be a person, okay? And then over time, people can run into quite difficult things with the persons becoming threatening or unpleasant, etc. And so I've had some patients who've gone from, there's the people, there's a chair in the room, it looks like a person, convince yourself it's not a person. Now there are little children in the corner of the room. They often are little in the corners. And now they're not very nice children. And now they're big adults. And they're friendly adults, well-dressed, and now they're unfriendly adults, and now they're murdering each other. And then we treat the hallucinations, and it goes right back in reverse in that same sort of order. And so it's really quite something what this happens, okay? You're not crazy. It's a part of the disease, okay? Sometimes you're seeing things that aren't there, and you have a hard time believing that they're not really there. And so I have lots of patients who will tell me, I have people living in my attic. Why do you have people living in your attic? Well, because you're seeing, it's very rational. You're seeing people in your room, okay? You know the door is locked. They must be coming from somewhere, so maybe they're living in the attic, okay? There's no one living in your attic, all right? It's a hallucination, so trust your spouse when they tell you it's a hallucination. Most people are able to recognize quite quickly that it's a hallucination and nothing else. So the main treatment is to let your doctor know about this. And there's 3 things that we typically do. First of all, we start to remove or change the medications. And there's a very specific order in which we do this. So the anticholinergics, Dr. Anang mentioned that for tremor, they always go first. Next is, in my list, is amantadine. Next is the dopamine agonist. Next are the MAO inhibitors. And finally, levodopa. Okay, so for hallucinations, typically people have a lot of hallucinations. They're on levodopa only. Okay, because it gives you the most bang for your buck, the least side effects for the amount of motor benefit. You can also treat directly with hallucination medications. There's a variety of hallucination medications that are out there. What I typically do is hallucinations can be a sign that the memory and concentration aren't doing so well. And so typically I will actually treat the memory and concentration disorders directly. So often what I'll do in my clinics is someone hallucinates, I ask them to copy a figure, an intersecting pentagon figure, and if you can't start it, I'm going to put you on a memory medication that melts those things away like you wouldn't believe, okay? So it's interesting that you treat the underlying cognition and the hallucinations get better. Anyway, that's for between you and your doctor. I can't give you individual medical advice, obviously. Let's talk a little about the autonomic system. Now, the autonomic system is autonomic as in we don't feel it working. And this is very affected in Parkinson's disease. So we have constipation, which is almost universal at some point in Parkinson's. It's part of the disease itself. It's not your medications, it's a disease. Erectile dysfunction, urinary problems, and blood pressure drops. Let's run through those a little bit. So constipation is kind of interesting because it turns out that people who are constipated later in life are at higher risk of getting Parkinson's. I'll show you that a little bit later, but it's one of the earliest manifestations of Parkinson's. If you're constipated, what can you do? Well, keeping your fluid uptake can be useful. Of course, if you have bladder problems, that can be difficult for you, so it's not always a good solution, but make sure you're getting enough fluids, obviously, right? An active lifestyle helps. If you're moving, your bowels move too. Fiber, bran flakes, the like that go on the cereal, that can certainly help. The Metamucil that you buy over the counter, that can help. That typically doesn't help very much. In my experience, my favorite first medication is the herb that you can just go and buy as a tea, or you can get it over the counter as well. It's called senna or senocot, and it's just a natural herb. The Chinese herbs often have these in them as well. It works quite well. It's a stimulant. It's an irritant, essentially. Gets your bowel moving. And if that doesn't help, there's a whole list of laxatives that can help. I personally not worried about taking a bit too many laxatives with Parkinson's disease. Many people worry that they're going to get diarrhea. Of course you're going to get diarrhea, but your gut gets used to it. I don't think Parkinson's gut can get used to anything. There's no nerves there to get used to anything. Whatever it takes, just make it work, okay? And don't worry about it too much, okay? Just get them moving. And there's a long list of things that you can use. How about the bladder? So the basal ganglia, the motor area that I showed you, helps stop you from peeing, okay? And so what happens in Parkinson's disease is that you get more of an urge. So when you have to go, you have to really go, okay? It's always good that we give this right after the break because everyone's had their chance, because I've all reminded you about your bladders. And then many people notice that they have to go very often, and almost everybody with Parkinson's notices that they're up in the middle of the night at some point to have to pee. So that's the classic problem. There's another classic problem that every man in this room needs to be aware of, okay? Because when you present to your doctor and you say you have bladder problems, the first thing the doctor's going to think about is your prostate the problem, okay? And I've had many patients who've had a prostate operation for their bladder problem, but it really was the Parkinson's and not the bladder, not the prostate, and so they've had an operation for nothing. How can you tell the difference? Typically, and not always, but typically in Parkinson's disease, when you start peeing, it comes out fine. Okay? In a prostate problem, you can't get going and there's dribbling after it. The stream is very hesitant. Okay? So if your stream is not hesitant, if it comes out quickly, it's not your prostate, don't go for an operation. So the management, scheduling bathrooms, obviously that can help. There are a few medications that can be used. Some of them can hurt the memory a little bit, so we're a little bit careful with them. There are some new ones that don't hurt the memory and raise the blood pressure. That can actually be a good thing, as I'll show you in a second. So there are definitely medications that can help this. Sexual dysfunction, okay, can be a part of Parkinson's disease. It's more noticeable, obviously, for men who have erectile dysfunction, and about at least half of men with Parkinson's have erectile dysfunction. Of course, most men of that age have some erectile dysfunction as well, so it's hard to tell the difference between this. The usual medications like the Viagras and all those great commercials, they probably help as well in Parkinson's disease. So if that's an issue for you, you certainly can. There's another thing that you should be aware of, specific to those dopamine agonist medications, so that's the Mirapex or the Pramipexole, the Requip or Ropinirole, or the new patch, the Rotigotine, is that sexual drive can be increased and can be abnormal sometimes as a side effect of those medications. And so if you're getting interested in things you didn't used to be interested in, or if you're needing sex all of the time, it might be a side effect, and you could probably stop the medications or reduce the dose and it goes away instantly. But just be aware, if you're having problems with this, watch your medication list, okay, because you can get rid of it. And that goes as well for excessive spending and gambling, addiction to video games, that sort of thing. If this is happening to you, it's probably your medications, okay? It's the dopamine agonists, not the levodopa, that do this. Orthostatic hypotension. So what that means is blood pressure and blood pressure drops, okay? And so what we see in Parkinson's disease is the blood pressure when you're sitting or lying down is not any different, but when you stand up, the system that controls the blood pressure to keep it up stops working. And so this has a practical aspect. So 15 years ago or whatever, you got diagnosed with high blood pressure and you're taking blood pressure pills. Now you have Parkinson's. Parkinson's is a blood pressure pill. Okay? And so what happens many times is that you no longer need the blood pressure pill, or the blood pressure pill is causing side effects. And the classic side effect is you stand up and feel dizzy. So if you're standing up and you don't feel well when you stand, okay, but you're fine when you're sitting down, and we're not talking about walking, but in the head, don't feel well, check your blood pressure and see what it's doing when you lie down and see what it's doing after you stand up. It's not always dizzy. Some people will notice that they get faded out. They don't feel quite right. They're a little foggy. There's something called coat hanger pain. Whenever you stand up, your neck and shoulders hurt in a coat hanger distribution. So there's some atypical symptoms that you should be aware of. And if you got a blood pressure machine, you just check your blood pressure and you know that what's the problem. There's lots of things that we use for this. My favorite is domperidone, called Dom Perignon. It's like champagne. No side effects, works like a charm. Also very good for nausea. And there are a list of other medications that one can use for this problem as well. I'll just show you some new science because this is kind of neat. This is not a study that we did, although we actually we did something like this. This is your blood pressure. This is Parkinson's patients doing a bunch of cognitive tests when they're lying down and when they're standing. Okay, and that little red line that's going across the screen, that means that you're the same whether you're standing or lying down. And if you're below that line, your cognition is dropping whenever you stand up. And there are two people in that group. It's very hard to see, but you see a whole bunch of white things, the white circles, and you see a whole bunch of black circles. So the white circles are people who don't have blood pressure drop when they stand up, and the black circles are people whose blood pressure drops. And what you can see is many of the cognitive tests in the people whose blood pressure drops worsen as they stand up. And so be aware of this if you are foggy when you stand up, okay, or if you seem out of it or faded out or not very smart whenever you're standing and okay when you're sitting, check your blood pressure again. And again, this is a fixable problem. I always wonder how good it is for your brain to be dropping your blood pressure by 30 millimeters of mercury every time you stand up. It can't be a good thing for your brain. So I've always wondered if it's important to recognize this and treat it quite promptly to prevent cognitive problems from occurring on a more permanent basis in the future. So check your blood pressure at home. Let's talk about sleep. That's my daughter when she was born. My first daughter. She is now 12. So yeah, now you know how long I've been giving these talks. But that's her. So lots of sleep problems in Parkinson's disease. Usually in Parkinson's, the insomnia occurs in about half of Parkinson's patients. And the classic insomnia, Parkinson's, is not difficulty falling asleep, it's difficulty staying asleep. So you fall asleep at 9 in front of the TV and you wake up at 2 and you can't get back to sleep again. That's the classic pattern of Parkinson's disease. Now this is probably an intrinsic part of the disease as well. We don't know when it starts, but it does seem to be almost universal pattern at some point. And so it's not necessarily the medications, it's the disease itself. And it's actually an exaggeration of the normal changes of aging, right? Everyone knows that the older you get, the earlier you get up, right? That's classic aging. And so this is sort of an exaggeration of that. There are a few things that one can do if it's a big problem. The first thing I often say is don't always think it's a big problem. Maybe you can go with it, okay? In the Middle Ages, when people didn't have electric lights, there's actually literature out there about first sleep and second sleep. And what would happen is people would fall asleep from boredom at 9 o'clock, and they'd wake up at 2 o'clock with their, sleep centers fully refreshed, go and putter around for a couple hours by candlelight, and then go back to bed again. If that works for your lifestyle, go with it. Maybe you don't need any medications at all. Maybe that's fine. Okay? Just accept it. One thing we always watch out for is the Parkinson's, the motor part of Parkinson's, keeping you awake. And this is a very common problem in people whose medications wear off before it's time for the next one. Because you can imagine, you just took your pill, say at bedtime, it's 5 hours later, your medications are off, thump, thump, the tremor against your chest, or you're stiff, or you're sore, or you can't turn, or maybe you even don't feel it. And sometimes we'll use medications in the middle of the night, and people can then fall back asleep again. Treatment of sleep onset, maintenance insomnia, so difficulty staying asleep, is very difficult. Sleep hygiene techniques, the classic things that you're taught about insomnia, like avoiding coffee and all that sort of stuff, really apply to sleep onset insomnia, difficulty falling asleep. The one piece of advice that I give everybody is if you can't sleep, do not stay in bed. Because what happens is you start to create an association between the bed and this horrible torture chamber where you lie awake thinking about how you can't sleep. And that association makes you unable to sleep. So if you can't sleep and you're physically capable, get up, read a book, okay? And when you feel tired again, go back to bed again. Don't lie in bed for 2 hours at a time thinking about how horrible it is that you can't sleep, because it makes the insomnia problem worse. There are some medications that are used, but they're totally different than the medications that are used in insomnia in the general population, okay? Which are all designed to help put you asleep quickly and wear off as fast as you can so you're not sleepy the next morning, which of course is not your problem. You're having no trouble falling asleep. And so in fact, the old antidepressants, doxepin, we did a study on doxepin, now there's another study of trazodone. These used to be used at depression, but when you get to the very, very low doses of them, they're not depression medications, they're what's called antihistamines, kind of like Benadryl. And in elderly people without Parkinson's disease, there's very good studies that really have suggested that they help specifically at the maintenance stage of insomnia. Okay, so in hour 5, hour 6, hour 7, no one needs to sleep more than 7, you don't need more than that. That's where it helps you stay asleep. And we ran a little study of that in Parkinson's patients, very little study, let me emphasize, but we did find it was very effective at treating insomnia. And there's a theoretical concern about cognition with these, but in fact the cognitive scores of the patients who were treated actually improved, probably because they were sleeping better and able to concentrate. And quality of life is better. So I do like using these medications if you otherwise can handle them. How about sleepiness? Well, sleepiness is common in Parkinson's disease, but it occurs later. Okay? Now, there are many, many causes of sleepiness in Parkinson's disease. The one that you're all going to assume is, well, I had a crummy sleep the night before, so that's why I'm sleepy today. But in fact, probably not on average. It tends to be the people who don't have insomnia, who are the same people who have difficulty with too much sleeping. And so they have a general increased sleep drive. They're sleeping 12, 14 hours a day. The medications can definitely cause sleepiness. The dopamine agonist in particular, but also levodopa. Many people get a half-hour real sleepy period after they take their levodopa each time, okay? And that can be a problem if it's interfering with your life, of course, and there's not much you can do about it when it does happen. But because it occurs later in disease, it's mostly a primary manifestation of disease. One thing to be very aware of, and I tell all my Parkinson patients who are sleepy like this, people with Parkinson's cannot fight sleep in the same way that other people can. Okay, so a Parkinson's patient can fall asleep in 1 second. And so the implications of that are, if you are driving and you feel your eyes going low, or you're feeling like you're fighting sleep, remember, I'm not normal at fighting sleep. Pull over, okay? Don't fall asleep in front of the wheel. Whatever it is, find the earliest safe place to pull over, have a sleep, whatever. Power nap, something like this, and then refresh yourself and go again, because sleep attacks at the wheel certainly do happen in Parkinson's disease and can have obvious important implications for you and other people. What are the treatments? Well, there's not a lot of treatments. There's something called modafinil. It costs $2,500 a year, so it's very, very expensive. It does help a little bit. There's something, Ritalin, you know, the attention deficit medications that the kids use, that actually works, a bit to my surprise. The government in Quebec, we have a sort of provincial healthcare system, and the government, for some arbitrary reason, made us all try Ritalin before we tried modafinil, and I was grumpy about this, and they made me do it, and then I found, oh, it actually works half the time, so it wasn't so bad. So that's another option. There's a new medication out there which also helps sleep. It's costs, I think, between $15,000 and $20,000 a year, so we won't mention that for now. When the price drops, we'll start putting it in talks. It's also incredibly difficult to diagnose. It's the date rape drug, actually. It's the Bill Cosby, you know, that one. That drug actually is very effective for sleepiness and Parkinson's disease, but you have to, you know, it's very, very difficult to prescribe for obvious reasons. There's one other option, which everyone was lining up for today. Coffee, okay. I actually noticed a lot of people lining up for coffee, which is a bit of a change compared to 10 years ago. So it's been known for actually about 20 years that Parkinson patients don't drink coffee. Unclear why that is. There was some suggestions that maybe it's a medication and so you don't present. Could it be neuroprotective? I actually think it's probably the Parkinson's personality. There actually is a Parkinson personality, and you don't respond to caffeine as much as you as people who, you don't get the same sort of self-reinforcing cycle that makes you want coffee. We actually did a study on this. You might have heard about 5 years ago, it was all over the press, a study. That was our preliminary study. We've done a more definitive study now. And what we did find is that there was some improvement in sleepiness with caffeine, but this is it's a chart. I don't want to go through it because I can't point at it. But what you see is you see an improvement over about 3 months, and then you get used to it. So caffeine every day doesn't really help your sleepiness, but you know, you're going out for dinner, have a big cup of coffee, no problem. Okay, you'll stay a little bit more awake. It's sort of a good treatment to use as needed. There was suggestions that it helped the motor state of Parkinson's disease. That's what hit the news. And so we've actually shown that that is not the case. Okay, it looks like that was just a temporary effect that wore off very quickly with time. So caffeine is not a medication for Parkinson's disease as far as I'm concerned, but you can feel free to use it like everybody uses it. It's perfectly safe for your health. I want to finish with one last disorder, okay? This is REM sleep behavior disorder. So I don't know if you remember when you were young, you would have those dreams where you were trying to run, you couldn't run, or you're trying to yell and the voice wouldn't come out right. That's because you can't run and your voice doesn't come out right. That's normal. Okay? Normally when you dream, you're paralyzed. And what happens in Parkinson's disease is that the system that keeps you paralyzed when you dream breaks down. And so people are now capable of acting out their dreams. So whatever they dream, they do. They talk, they yell, they thrash, they fight, etc. This comes and goes a lot. I find the medications really, in general, the Parkinson medications, I think, drop it down a little bit. But sometimes it really comes and goes a lot in Parkinson's disease. The ultimate diagnosis is you actually have to have a sleep study. You have to go to a lab and they measure your sleep and they can document it. I think practically that's a little bit difficult for many people. And so there are a variety of treatments. First of all, some of the antidepressants can trigger this. And so if you start an antidepressant and this happens all of a sudden, stopping the antidepressant if it wasn't helping you, that'll make it go away. Bed safety is the big issue to think about, okay? This doesn't really disrupt your sleep in any other way. The real problem is injury to yourself and to your spouse. So the cure, in quotation marks, of REM sleep behavior disorder is a mattress on the floor with no sharp objects around, sleeping by yourself, okay? Because the only problem about REM sleep behavior disorder is usually hitting your wife. It's usually men hitting the wives in the middle of the night. That's the classic thing. If it's a big problem, we definitely use medications. Melatonin is my lead one because it has very few side effects. And there's another one called clonazepam, which can make you sleepy and can affect your cognition a little bit. So we use it when we really have to in Parkinson's disease. I want to finish with a little bit of research, okay? Just about 5 slides, so if you're getting tired, don't worry. This is one of the hottest areas of Parkinson's disease, without question. So you remember I showed you that slide earlier about the staging system of Parkinson's disease. And some of you who are paying attention went, hey, if Parkinson's disease starts in the non-motor areas of the brain, then maybe you would be able to predict Parkinson's disease by studying the non-motor areas of the brain. And in fact, that turns out to be true. This is one example, olfaction. Remember those scratch and sniff things that I showed? In 1971, there was a study done for atherosclerosis and diet, okay? Had nothing to do with Parkinson's disease. But in 1991, they decided, let's test everybody's olfaction. And this was an autopsy study. So everyone who died would get an autopsy and we could confirm whether they got Parkinson's disease. And so in 1991, they tested whether people had impaired sense of smell, and then they followed them over time. And what you can see, that green arrow there, is those who had a decreased sense of smell had a 5-fold risk of developing Parkinson's disease in the future. Okay? So olfaction was predicting Parkinson's disease. Now, it's not a very good predictor. Those of you who can read the fine print might notice that there are 549 people with impaired olfaction, and only 10 of them got Parkinson's disease. So it's not a very good predictor of Parkinson's disease, but nonetheless, it is a predictor. Turns out to also predict Alzheimer's. Here's another really interesting one. Here's constipation. So they were asking about diet. So now we're going back to 1971, okay? And they asked a simple question: how often do you have a bowel movement? All right? And if you said you had a bowel movement less than once per day, your risk of getting Parkinson's disease compared to those who had a bowel movement more than once a day was about 4-fold increase. 25 years before, constipated people have an increased risk of developing Parkinson's disease. Now, how early is Parkinson's really starting? Is it starting that early, or is it maybe a risk factor for Parkinson's? No one knows that. Those aren't very specific. 95% of people who are constipated won't get Parkinson's disease. So it's not very useful as a diagnostic test. But that REM sleep behavior disorder that I told you about is a very, very different thing. So this is a study that we published a long time ago. Actually, we've shown this now for many, many years. This is what's called a Kaplan-Meier curve, okay? You don't need the name. But essentially what you're looking at is at the far left of the curve is people who have REM sleep behavior disorder who have nothing else wrong with them. Okay, so they're showing up in a sleep doctor's office, mainly men, hitting their wives. That's in the middle of the night, okay? Because that's who goes to a doctor's office, people who've hurt themselves or other people. And every time that tick goes down, somebody develops Parkinson's disease or dementia with Lewy bodies, which is related to Parkinson's disease. And what we found is that about almost 10% of patients per year develop Parkinson's disease, and it turns out that about 90% of people who have this disorder will eventually show up in a doctor's office with either Parkinson's disease or dementia with Lewy bodies. And this is by order of 100, the strongest predictor of Parkinson's disease out there. And so you can imagine that this is a major research opportunity. If you can diagnose Parkinson's very, very early, and we had neuroprotective therapy available, in other words, preventative therapy available, which so far doesn't exist, this would be a major advance, and you could actually prevent Parkinson's from ever showing up clinically. So, I'll stop there, okay? So to summarize, we know a lot about motor Parkinson's. You heard a whole talk about that an hour ago. But what you may have heard about less is the non-motor features of the disease. And I think it's very important to be aware of this. And I know that was a long and somewhat overwhelming list, but I think it's important to hit them because, as I've illustrated, these are very treatable things. And there's a missed opportunity if you don't recognize that this is part of your Parkinson's disease and get it treated if possible. It also implies that the disease of Parkinson's starts earlier than we think. So we were very aware of this and this very vast body of information that exists out there. And about 10 years ago, actually, I had written a book on non-motor Parkinson's disease. And when Julius Anang was training with me, we thought, well, let's update this. There's a lot to know about Parkinson's disease. Let's write a whole book. And that's what's sitting in front of you right now, okay? This was written, we sort of did the first draft, and then the person who puts it into proper English is the McGill Patient Education Center. And they're responsible for all the the terrific graphics that really help illustrate and make it easier to read, and the setup and the font. And then Parkinson Canada has been quite instrumental in translating it into French and also providing and distributing the copies that are sitting in front of you. So the goal really is to help keep you aware. It's free for use. You can share it with anyone. There's a PDF that you can get on the internet. Okay, you just type in, I think they showed you already, go to the Parkinson's Canada website. It was in the What's New section, now it's in the Resources section. It's free, okay? You can print it, you can give it to anyone. As long as you don't sell it, okay, you can give it to anybody you want, all right? And so the goal of this was to really help people put the information in the hands of you, the people who need it the most, because talking to doctors has its limits. They have lots of things that they need to remember, but you're the most motivated people to hear about these things. So with that, I'll stop, and thank you. Switch mics? Okay. Yeah.
Okay. Thank you. It's on. Okay. Thank you so much, Dr. Postuma and Dr. Anang, if you don't mind coming up.
He'll stay there. We've decided.
You've decided you're taking...
Specifically for him, ask him and he'll come up. If not, I'll take it.
You'll take... Okay. All right then. Perfect. Perfect. And book signing is after this, right? All right, so Grace over there, a lovely lady standing at the other end of the room, and I will walk around, put your hands up, and you can ask a question with the microphones.
Yeah, those of you who are live online, I think you type in questions, and then we read them, and we'll try to mix the live and the online. This is on, hey? Okay.
Thank you very much for a very enlightening presentation. I'm just wondering, is Parkinson's hereditary? Am I going to give it to my daughter, or is she safe?
Well, so the short answer is not very much, okay? So the general rule of thumb is if you have Parkinson's, your kids have about a doubled risk of developing Parkinson's than someone else, and your siblings, brother and sisters, have about a triple risk. Now that sounds like a lot, but remember only 1 in 100, 1 in 50 people are ever going to get Parkinson's. So if you're the child of a Parkinson patient, it's about 1 in 25, okay? Something like that. In their whole lives. Maybe 1 in 50 is a better answer to that. So not very much. It's not like other diseases, Alzheimer's, which is much more hereditary. It's less hereditary than most. Now, there are some exceptions, okay? There are some ethnic groups who have higher risks. Of course, people with family histories, if you already have a family history, you're at a higher risk. So generally, plain vanilla Parkinson's disease, not a very increased risk.
Thank you for the talk this morning from both of yourselves, both professionals. What I'd like to know about is there anything that you can do for sweating or perspiration?
Not very much. Sweating can be a big problem in Parkinson's disease. The one thing that you look out for is if you are a person who fluctuates, has on and off periods, the medication wears off before the time of the next, and you start sweating, look at the clock, okay? It's probably a sign that your medications are wearing off. Okay. That being said, there are other people who have just general increased sweating, and unfortunately there's not really much one can do about it. It's a lot of shirt changes, huh?
Thank you very much.
Is there any adverse consequences from taking levodopa to your cognitive effects?
So the short answer is not really. In fact, there are some aspects of cognition that clearly get better with levodopa, and there's some aspects that get a little bit worse. The overall thing is a wash. If it's not making you sleepy, of course, if you're sleepy, then you're not quite as alert. But in general, cognition is a little bit better with levodopa.
Oh, hi. Dr. Nang referred to, I believe he called it a DAT scan, and I may have written that down incorrectly. First of all, is it available in Canada? Second of all, is it a good definitive test, or is it poor? Yeah. And does it work better for certain age groups?
So what a DAT scan is, it became available in Canada, like, I think it's coming out like in a week. It's been available in Europe for 20 years and in America for 15 years, okay? What a DAT scan is, it's a test to tell you if there's something wrong with that substantia nigra system, okay, if it's decreased or not, okay? It doesn't tell you why. So it's not a diagnostic test for Parkinson's disease if it's clear that you're Parkinsonian. Okay, so you're shuffling, you're rigid, you have a rest tremor. There's no doubt about Parkinsonism. Okay, then there's no point in a DAT scan. It doesn't help you at all because it doesn't tell you why. Okay, I think what it's going to be used for when it comes out is I'm not sure this person really is Parkinsonian. And so the classic one would be a person who has a tremor and it's here at rest and it's also at action and isn't maybe this other disease called essential tremor. That sort of thing. In selected cases it'll be useful, but it's not a diagnostic test for everyone, that's for sure.
Hi, thank you for your talk. I just wanted to ask you, I was interested in the people who are treated versus not treated that you were talking about before, because I had a brain hemorrhage that led to some lesions in the basal ganglia and Parkinsonian-like syndrome and dystonia. But for some reason, I'm not getting a prescription for levodopa because there's a belief that it might interfere with the normal chemistry and healing of the brain. Can you talk about that at all, whether there would be any risk in getting levodopa?
Okay, so I can't offer any individual advice whatsoever, okay, because I'm not your doctor, okay? There is no evidence that levodopa is toxic to the brain, period. And it doesn't interfere with healing, period. Okay, there have been people with misdiagnosed Parkinson's, this other condition I just talked about with essential tremor, okay, who got levodopa for 30, 40 years, okay, and they had autopsies after they died of other causes, determined they didn't have Parkinson's, but also determined that there was nothing wrong with their brain. The areas of the substantia nigra were not affected at all by the levodopa. Levodopa is not toxic to your brain, okay, full stop.
Dr. Postuma, I'd like to congratulate you on a superb presentation.
Thank you. Thank you.
I note that we're both fellow alumni of the Manitoba Medical School, which probably explains it.
Yeah, all neurologists come from Winnipeg, you know. Yeah.
I was so interested to hear you set out these soft markers, I would call them, of Parkinsonism. And these seem to be not generally well known or acknowledged by physicians. My wife has had several of these. I'm a much punished husband myself. And for years, we saw many doctors, and it was only after many years that the diagnosis was made by a psychiatrist, believe it or not. I just wonder if any progress has been made in the general education of the medical population about this.
It's interesting because this disorder, REM sleep behavior disorder, was described in 1986. So it's a new disease. It's only 30 whatever years old. So that's really interesting that, you know, people have been telling their doctors about it for millennia, you know, and this was just thought to be normal, right? You know, because people sleepwalk normally. So it took a researcher to sort of go into it and figure it out. So awareness is definitely limited of this disease. Now, how much does it matter? This is the tough question. So does it do you any good to know you're destined to develop Parkinson's disease in 15 years? Not really right now. Okay. Now that may change if we ever have a therapy for Parkinson's disease that actually slows down the underlying degeneration. In other words, not replacing chemicals that are missing, but actually stops the aging process under Parkinson's disease. Now we have different stakes. Now we've got to go find people who don't know they have Parkinson's yet in the general community. And so this is a very, very active research area, and many of us are working on this quite actively. But it's all for a future payoff, which hopefully will happen someday.
Hello, my name is Judith, and I've been diagnosed about 3 years ago now. I suffer from the insomnia. I have been up since 3 o'clock this morning, and if I were home, I would probably take a short nap in the afternoon, maybe an hour. But I just find that I don't sleep like I used to, and the insomnia is dreadful. I know you can't recommend, but I've been to the pharmacy, and you can buy things like Tylenol PM with, I think, Benylin or something in it to give you a drowsiness. I'm not one to take something that's not been recommended. Can you just give me an overall? I know you can't recommend it to me, but...
Yeah, I get it. So power naps, the first part of that question, power naps are probably okay. okay? In fact, I kind of encourage them just not after 5 p.m. because then you can't fall asleep. But remember, power naps are really to prevent you from having difficulty falling asleep. That's the advice we give people who have trouble falling asleep. It has nothing to do with difficulty staying asleep. So go ahead and power nap if it works for you, okay? Tylenol, there's not a lot of studies on it. But I've had enough experience, myself even, I think it's a bit of a sleeping pill personally, and I don't know why. But it may help a little bit. Now, Tylenol every single day, you got to think about your liver a little bit. So, you know, it's something that's probably acceptable, okay? But again, I can't really advise. There's no studies on it.
Okay. My name is Brian, and I'm wondering about the link between depression with Parkinson's and this sudden fatigue that we're noticing halfway through an activity. Suddenly, the energy level has dropped so quickly, and is that related to the other thing that we're noticing, and that is oversleeping? Like 10 hours of solid sleep, well, with breaks for washrooms and things like that. But is that all linked?
I don't think they're linked. So depression really sits outside of a lot of the other manifestations. Remember that cluster thing that I showed you? Okay, that whole big thing? So depression is actually not that important in determining the other manifestations of Parkinson's. In general, it's its own thing. So fatigue is, yeah, some people really notice a lot of fatigue. The obvious thing is, am I undertreated? Do I need a little bit more dopamine so I don't get so tired? That's the very obvious thing that one would think about. But some people have it, and it's really tough, and there's not much we can do about it as well. Yeah, but not linked. Yeah, and not linked to sleepiness either.
I was just wondering, does Parkinson's cause kidney failure?
No, it doesn't cause kidney failure. Yeah.
Thank you.
Yeah. My name is Jose. I would like to know what is the side effects of taking Viagra.
Blood pressure drop is the main side effect of taking Viagra. So after, don't stand up too quick. Stay in bed and cuddle like you're supposed to. So inappropriate. Go ahead, yeah.
I have two short questions. One is, could you talk about Parkinson's around the world? And second is there any advantage in diagnosing Parkinson's very early?
So Parkinson's around the world, it's tough because it's a little difficult to do studies around the world. And this Ghana study that Dr. Anang talked about, for example, who knows how common Parkinson's is because people aren't aware of it and don't show up to doctors, and they show up a little bit later. There is not a lot of variability across the world. There are a couple of hotspots wherever there's increased Parkinson's disease in Tunisia and Morocco and Israel, and those are related to genes. Okay, there's a gene called LRRK2 and there's a gene called GBA. We have a bit of a cluster in Quebec of one gene in Parkinson's disease, but in general, it's a worldwide disease. There's not a lot of differences around the world. And your second question was? Advantage to an early diagnosis. The big thing about Parkinson's disease that we try to emphasize is you can't save your medications for later. It doesn't work like that, okay? And so the only advantage to getting an early diagnosis is getting early treatment. And there are some suggestions, in fact, that people who are treated earlier do a little bit better in the long run. So making sure that you're treated enough that you can be active, that you can be involved, that you can stay in shape, that your life doesn't drop off in sort of activity and intensity. I think making sure you're treated well enough for that is the only real advantage right now to an early diagnosis.
You started your talk with some charts about the different presentations of Parkinson's, and I'm wondering if it's important to know where you fall in that, and if so, how I would investigate it.
It's a little difficult to translate that to the individual level, okay? As a doctor who treats it, I recognize when I see particularly that diffuse subtype, which is, it's a tough subtype of disease. When I see that, it's all levodopa and nothing else most of the time, because I know that the side effects are going to happen a lot with the other agents, and so I really stick with the pure, you know, the most effective medication with the least side effects. If I see a person who's a very pure motor standpoint, and they're not going to have any troubles with like, these non-motor things, then I know that we can push the medications a little bit farther. They'll maybe do a little bit better. There are certain medications I'll be much less reluctant to prescribe. So there's a little bit of this, but it's not a rule. It's all a sort of sense of being experienced and sort of knowing where patients are likely to go. It's not something you can translate to yourself and change your treatments necessarily. Yeah.
Hi there. As part of this long list of bodily functions in the gastrointestinal tract, is there any news that acid reflux might be part of this scheme?
Well, so there's a couple of aspects to that. Let me see. So levodopa and all the dopamine medications can cause a cramping feeling in your stomach, which feels a lot like acid reflux, and that's a big side effect for many people. The domperidone medication that I mentioned just cures that completely, so that's why I like it a lot. There's not a lot of evidence of acid reflux per se as being part of Parkinson's disease. Yeah.
Hi, I'm Jasmine. I just want to know, would the Parkinson cause weight loss, ADHD, and shortness of breath?
So, okay, those three things. Does Parkinson cause weight loss? Yes, it can. Typically in later stages of disease. It's interesting, all the neurodegenerative diseases in general, so, you know, all of them, Alzheimer's, ALS, MSA, they all seem to be associated with weight loss for reasons that we don't entirely understand, okay? There are other reasons. People with dyskinesia obviously are exercising 24/7, so they can lose weight as a result of that. Attention deficit, you know, so the sort of classic attention deficit disorder like, you know, can't pay attention in school, not really. But one of the difficulties of Parkinson's cognition is a fluctuating inability to pay attention, sort of to attend to stimulus, you know. So the classic thing of a person who's really got cognitive problems is some hours they're wonderful and other hours they're terrible. And when I hear that, I usually use the medications, the cognitive medications, and they can actually help quite a lot to sort of fix you up. But the classic attention deficit, no. Yeah, not obviously. Shortness of breath, not directly, but there's one thing to be aware of. If you are a fluctuator, many people are showing up in emergency rooms with sudden onset of shortness of breath. And what this often is that you're rigid. And so when you're rigid, it's not just the muscles here that are rigid, but it's the muscles in the chest wall that go rigid. And your brain interprets chest wall rigidity as constriction, as you can't breathe. Okay, but it's a false signal. You're breathing perfectly fine. Don't go to the emergency room, okay? If you're off, if you're getting short of breath, and you're a fluctuator, and you're feeling it, look at your watch. Am I due for my pills? Oh, that's all it is. Okay, you can save yourself a visit. So stem cells are not going to work. This classic way we think of stem cells is you put them into an area of the brain, and they grow and reestablish connections. You cannot put stem cells into the entire brain. Right? So that's not going to happen. Now, could stem cells be used in other ways? Who knows? But it's a long way off. It's about number 10 on the most promising things in Parkinson's. There's a lot better options out there.
Thank you for sharing all that information. Do you have any comments on nutritional supplements modulating the progression of Parkinson's?
There's no clear evidence that any of the nutritional things affect Parkinson's other than just having a healthy diet, okay? Now, Dr. Anang has already mentioned the high protein can interfere with levodopa in some cases. Some people find that's an issue, some people don't. If it's not an issue, don't worry about it too much, but you're always supposed to take your pills before you eat, right? But in general, sort of nutritional supplements like the vitamins and et cetera, no, there's no real signal that any of those are doing anything particularly.
As I understand it, there is a possibility of getting some form of dementia sometimes when you have Parkinson. If there's already a history of dementia in the family, do you feel that chance is increased?
I think it depends on the kind of dementia. The short answer would be yes, I think. Parkinson's dementia certainly can occur in Parkinson's disease, more classically in the later stages, and especially, I think what happens to a lot of people is 30% of the population, 85 years old, has a little bit of Alzheimer's, okay? And they may live to 100 and never have any Alzheimer's changes at all. But if you have Parkinson's and it's starting to spread up to the same areas that are affected by Alzheimer's, the two of those two things together combining can really cause a lot of damage. And so, anyone who has that tiny little bit of Alzheimer's is going to probably get dementia if they live long enough, because it's the two diseases in the same brain is not a good thing.
Yes, Dr. Postuma, could yourself and Dr. Anang get together and publish a paper that could be circulated amongst the medical aspect of the province? Or has that been done?
Oh, yeah, what I'm showing here is a summary of thousands of papers. Yeah, this is an active area. You don't have to go very far to find medical papers written on this. Yeah, no worries there.
Yeah. Now, I was started on Azilect, was the first medication that I was given when I was diagnosed. Can you tell me a little bit about what Azilect does for Parkinson's?
So I think Dr. Anag mentioned the MAO inhibitors. There are two. There are selegiline and there are rasagiline, which is Azilect. They're basically the same thing. What they do is they keep the dopamine in the brain longer. Okay, so the natural dopamine that's in the brain stays longer, and the levodopa that you get stays around longer as well. Okay, it prevents the normal breakdown of dopamine. We normally break down dopamine. We had to get rid of it somehow. It's one of the enzymes that stops that from happening. And so it's a mildly effective agent. But it's a mildly effective, quite well-tolerated drug. It's usually not enough for more than a year or so, but it's not a bad one to have in the background. Yes?
Good afternoon. My name is Joe Pereira. I was inquiring about the medications. If I miss the 7 o'clock one for 9 o'clock, do I make up the time or do I?
Okay, so that is an individual answer that I cannot give, okay? So in general, people know their own disease, okay? So a fluctuator who's up and down every 2 hours, needs their medications. If they miss a dose, should they take 2 the next time? Maybe not, okay? Because that's a double dose and you're going to be dyskinetic all over the place. If, however, you're not a person who's not fluctuating very much and you're, say, a few hours late, in general, I would try to keep the total dose right, okay? So if you're supposed to get 6 pills a day or 8 pills a day and you forget a dose, as soon as you remember, take it, and then kind of take the next one, a little bit later, like split the difference a little bit. There's no rule to that, of course, but so if it's, you're supposed to take it at 12 and your next one was supposed to be at 6 and now it's 3, so you'd probably, it's 3, I forgot, I'll take it at 3 and I'll take the next one at something like 7:30. Okay, instead of midnight, that sort of thing. There's no right or wrong answer because it really depends on your individual response to levodopa, what one should do.
Okay, I think we're going to wind it. Oh, we see more hands. Maybe we'll take these last questions because we're going to break for lunch, and I'm sure we're all hungry. So you, sir.
Can you say anything about Parkinson's and alcohol? And I'm not talking about excessive alcohol, I'm just talking about social drinking. Is that good or bad?
Enjoy your wine, no problem. Yeah.
Okay. Is this on?
Yes.
Is there any reliable research on medical marijuana with Parkinson's?
No, not yet. The difficulty, of course, is you could just imagine. You can't do it in America because you know how America is. There are studies that are being launched on marijuana. I'll say I have many patients who use it now and again. I think it does help some things. Pain, maybe a little bit of dyskinesia, and maybe a little falling asleep. The videos that are out there of people taking a puff of marijuana and being cured of their Parkinson's are complete nonsense, okay? That's not like that at all. It's a symptomatic treatment, okay? There are cannabinoid receptors, that's what marijuana does, in the basal ganglia, so it makes sense it would do something. The downside could be hallucinations, paranoia, which is, of course, the side effect of marijuana. I think it calms people down a little bit, I'm not particularly worried about it. I will say my patients who ask, well, if you want to, take a puff and see what happens, that's fine with me. I don't think there's a lot of side effects of it. But typically the people who notice a benefit need very, very, very little, like one puff, and that's all they need. So there's no research, okay? But it's happening. Lots of people are very interested in it. It's the commonest question in every clinic. So I don't really know. Yeah.
Hi, my question is twofold. One is to do with very heavy and rapid breathing, and also I feel like out of breath as I've just run a marathon or something.
Yes. So
and
yeah.
Very heavy breathing.
So like I said, okay, if you're out of breath, look at the clock, okay? There are two potential explanations. You are off and rigid, or you're so dyskinetic that you've been exercising constantly and you're sweating like anybody would who's writhing around a chair, right? And so both of those are possibilities. And so we certainly see a lot of that sort of both sweating and shortness of breath as a result of both of those things.
I notice that when I'm upset or when I'm anxious about anything, it starts right away.
Yeah, you and everybody else. So tremor gets worse when you're upset and anxious. Dyskinesia gets worse when you're upset and anxious. They're not causing it. It's just it's a normal function of the brain. When you're anxious, you're upset, everything ramps up a little bit, and you move more, you tremor more, and it wears off when it's gone. Yeah, it's a very common phenomenon.
The question is, I have a lot of muscle mass lost. I only have skin and bones now. No muscles on the arms, legs. And that's in the last 6 months it has happened.
Okay, so I can't comment on you, right? But we do see people losing muscles in Parkinson's disease. They're usually losing fat more than muscles, actually. This is one of the reasons that it's very important to keep yourself doing exercise as much as possible. That's for sure. Yeah.
I think it's, oh no, it's on. Okay. So I think if I may ask a question, we know that there's a depletion of dopamine. Are there any other neurotransmitters that are depleted as a result of Parkinson's disease?
Yeah, I mean, I mentioned the depression. There's probably some depletion of serotonin. There's depletion of choline, acetylcholine. Yeah, there's a lot of other. The medication we use for memory actually give you acetylcholine back. The medication we use for depression are increasing your serotonin levels. So it certainly makes some sense. Nothing's nearly as effective as levodopa in terms of replacing dopamine. That's amazing. But the other ones, that you certainly can make a difference. Yes, there's a broad depletion in Parkinson's. Yeah.
Okay. All right. So I think that's it for today in terms of, or this morning anyway, in terms of questions.